Hi, everybody. Good afternoon, and welcome to the next of our Essential series. These are topical, engaging, and technical webinars designed to introduce you to the world of wealth and wellness with leaders in the private client world. I'm Lottie, founder of the Jura Society, and today, ahead of our intimate salon later this month at Montrose, I'm delighted to welcome Dr. Georgina Williams. She's a consultant reconstructive and plastic surgeon, and she'll be sharing her insights on the landscape of beauty and aesthetics, which is a very complex but also very topical topic. So I'm just going to welcome her in now. Hello, Georgina.
Hi, good afternoon. How are you, Lottie?
I'm very well, apart from the miserable weather, but that cannot be changed. That is out of our control. But thank you so much for joining us. It's lovely to see you.
And you.
So before we get started, who are you and what do you do?
So yes, thank you for having me. As it says, my name is Georgie Williams. I am a consultant plastic and reconstructive surgeon. I work both at Montrose, London, which I co-founded with some colleagues, and I do my private work there, which is mainly aesthetic with a little bit of reconstructive work. I also have an NHS practice as a consultant plastic and reconstructive surgeon, where I tend to do mainly breast as well as facial and head and neck reconstruction following cancer.
Wow.
I also have two children, aged 3 and 5, and they occupy me when I'm not working.
Gosh, well, wow. I mean, incredibly impressive, and I imagine quite a high stress job, but you clearly love it. So how did you get into this world?
Yeah, that's a good question. My father was a neurosurgeon, and I'd always thought that that was the career path that I would go down. I did an extra degree at medical school, as like a number of medical students do, and I did that in neuroscience. I did sorts of placements in neurosurgery, and then I got a registrar job in neurosurgery, and I think that was the crunch moment for me when I kind of thought, having done so many placements, that actually it wasn't necessarily the right specialty for me. It's great fun, amazing sort of anatomy, but actually I found that the outcomes for patients weren't necessarily always the most happy, and I find that quite challenging. And so, having explored different subspecialty areas, I thought that plastic surgery was ideal, really, in the sense that you can operate all over the body. You can operate on patients under local anaesthetic, under general anaesthetic, and on the whole, they have great outcomes. And they're obviously very happy with their reconstructions or even their aesthetic surgery, and it makes a huge difference to their quality of lives, and oftentimes for the better. So yes, that's how I ended up on here. I did my plastic surgery training through the London Deanery, and so I've been in London for the last 14 years, doing my training and becoming a consultant, really.
Gosh, wow. I mean, yeah, you must come across a whole array of different patients coming to you, and I suppose you've got that specialism almost through your experience of facial, breast, and neck. What does that look like actually when a client is coming to you?
In terms of the reconstructive work or the private work more?
Go both.
Okay, so for the reconstructive side of things, it tends to be patients who have a diagnosis of cancer, and they need to have, typically for the breast work, it will be someone who needing to have a mastectomy, and they need to have, they choose to have a reconstruction of their breast. Typically that's two routes, so they either go down the implant-based reconstruction, but the thing that we do the vast majority of, and that's at Charing Cross, is reconstructive microsurgery. So taking a section of their body, so typically their tummy, skin and fat, along with the blood vessels that supply the skin and the fat, and then suturing those tiny blood vessels under a microscope to an artery and a vein under a rib in their chest, and reshaping and then remolding that skin and fat into a breast. So that's an example of reconstructive work. And then it kind of lends itself to the aesthetic side of things. So when patients then come and would like to have a a refresh essentially of, let's say, for example, their breasts. If they've completed their family, they've had children, they've breastfed, and they feel like their breasts commonly after that sort of sequence of events, your breasts may deflate, may sag, and you want to sort of regain your body confidence. And the same applies for the face and the neck. I do a lot of non-surgical aesthetics as well, which I didn't mention, but I do, say, Botox and fillers. And through setting up Montrose, London, we've got access now to a lot of machines, so energy-based machines for skin tightening or skin rejuvenation in the form of lasers. But there is a point at which your non-surgical aesthetics will take you, and beyond that point, really, you need to sort of switch to surgical rejuvenation. So, your Botox brow lift will no longer work beyond a certain point, and then you're looking at having an actual surgical brow reset, we call it, or an upper blepharoplasty, let's say, for example, removing a sliver of skin from the upper eyelid to help rejuvenate that upper face. And then similarly, lower face, we're talking facelifts and neck lifts. So it really is, in the private and the aesthetics sector, for me, a continuum of patients who want to go from non-surgical, minimally invasive, to fully surgical, and kind of want to take that leap.
And so what sort of age do you find that clients are when they are switching to the surgical? Because I think in my my very small little assumptions, I feel like maybe people are going younger because they're thinking, I just want to get it done once and get it done properly earlier on, perhaps. Or is that just a stupid thing that I've just made up?
No, not at all. I mean, it's a thing that I get asked not infrequently, for sure. And the answer to that is that the sort of right age to have it done varies really according to each patient, their genetics, what their environmental exposure has been like, and so what their skin and their tissues are like at that point in time, and also what their aims and their goals are. So I will see patients in their 40s who have a lot of skin laxity, quite a lot of wrinkles really for their age, and I'll see someone who's in their sort of late 60s who will be developing that sort of level of laxity. So, it very much depends on each individual patient's aging. The one thing I would say, though, is that if you have it done at that earlier stage, and you could benefit from having it done, doesn't mean that it will preserve you throughout time. You still continue to age, and facelifts do sort of wear off over time, so to speak. Not wear off, but you continue to age, and therefore they do need revision.
It moves with you.
There are different types and different techniques of facelift, and each have their own sort of longevity, but they are not an indefinite procedure that you will, never need to have repeated again if you have it done at, let's say, 40. If you are in your 60s or 70s, you may never want to have another one done because you're very happy with the way you look. In 10 or 20 years, you still look pretty rejuvenated compared to how you were, but it's not a be-all and end-all one-stop shop type thing, if you see what I mean.
Yeah, definitely. And I think as well, just going back to, the work that you do with breast reconstruction, there's, it's a special day today, isn't it? I think it's Breast Awareness Day.
Yes, 1st of October, so this is Breast Cancer Awareness Month, exactly.
Yes, exactly. So I imagine the work that you do there has got a very different sort of psychological impact, perhaps, or do you think it's sort of equal impact?
I mean, you're right. They both have huge psychological impact, but completely different. In the sense that patients who have breast reconstruction surgery are typically very shocked by the whole thing. I'd say the majority of patients who are needing to have a mastectomy and reconstruction are having it for an existing breast cancer. There are exceptions to that. So some patients will be having what we call a risk-reducing mastectomy. So let's say, for example, someone who's spoken about it quite openly, Angelina Jolie with the BRCA gene. So doing that mastectomy ahead of time to remove the breast tissue to reduce the chance of developing a breast cancer in the future is one context where you don't have breast cancer, and you have a little bit more foresight and a little bit more planning. But on the whole, breast reconstruction surgery and mastectomies happen quite quickly for a patient. So a lot of information is taken. You know, you have breast cancer, you have to have your breast removed, and you need to have a reconstruction. And so your patients often feel like they're being they're having to have something that they never wanted to have. They're losing a breast, and therefore the breast that you are reconstructing is not something that's associated with a life choice that you have made, and it's proactive and wonderful. Whereas, and that's a real shame. But what I do enjoy about my job is, and all of my colleagues feel the same, is that you feel like you're able to provide a patient going through that some sort of stability and hope that actually their reconstruction is going to look good, and they're going to get sort of body positivity out of it, really. On the flip side, the psychology of either non-surgical aesthetics or cosmetic surgery is that you're taking someone who is typically normally well, and you are making them feel better about themselves. So
an enhancement.
It's a very different starting point.
Yeah.
And ultimately, I think at the end of it, both patients are happy, but it's totally different. You're looking to make an improvement on yourself of your own volition in your own time if you're having aesthetic surgery done.
Yeah. And that is something I imagine you have a very good bedside manner about dealing with, because, you know, if we look at the aesthetic side of it, oh gosh, I remember, did you read that book, Psycho-Cybernetics? You read that?
No, I need to write that down.
So that is a fascinating book. Oh God, I want to say Max Kurzweil. Sorry, obviously it should.
Okay, no, it's good.
However, he was a plastic surgeon for a long, long time, and he really did a lot of research into how the way you present yourself will have an impact in your life. So anybody watching this wants to go out and do that. That was a really rubbish overview that I've just given you. However, it is an incredibly powerful book. So Psycho-Cybernetics, and it's all about what you do with your body to enhance your life. I think it falls into self-help section, but that is really, really poignant.
I'd love to read that.
Yeah, there you go, some homework. That's all I can do. I can recommend books. But yeah, I think that's quite a helpful one. And so when we're looking again on the psychological impacts, do you ever see, you know, a huge transformation or what, I don't know, what do you see?
So if we're talking about the aesthetic side, I think there's sort of non-surgical aesthetics and cosmetic surgery have an absolutely incredible impact on patients' psychology. There's no doubt about that. It's been sort of, if we take, for example, breast reduction surgery, there's lots of scientific data surrounding the psychological improvements that patients have after they've had a breast reduction. So just to reduce the size of their breasts. They may have had it done because they have back pain or shoulder pain or just the heaviness of the breast. You can get problems with the skin underneath the breast if you have large, heavy breasts, or it can really limit what you wear, your ability to wear swimsuits, to be able to wear tops, and actually to exercise as well. So that's just one example of, you know, functional and psychological benefits of cosmetic surgery. And I've had patients who've had sustained sort of weight loss following a breast reduction because they're able to sort of exercise, they're more motivated to get into sportswear and go running or go to the gym. But also when we're talking about facial work, sort of the tweakments or non-surgical aesthetics like Botox and fillers make a huge difference to somebody's personal confidence and self-esteem. And I find that with patients who come back and have treatments to make them continue to look refreshed. All of my patients tend to be patients who want to look natural, who specifically don't want to have a done look. They don't want people to know that they've had anything done to their faces. But that sort of that body positivity and self-esteem, it's tremendous what you can achieve. And the same applies for the surgery. I had a patient recently who was coming for Botox, and after a period of getting to know her, she sort of said to me, well, what do you think I need? And I'm not really sure. And I said, the one thing that sort of what stands out to me is that the Botox sometimes makes the eyelids a little heavier and you've got a lot of excess skin. And she said, I've always thought that. She subsequently then found out that her mother had had an upper eyelid lift before and had never mentioned it to the daughter. And so we sort of went through the consultation and we let her have a cool down period and have a think about it. And she had it done, and she said that it is the single thing that has really transformed her life and her confidence. So it's incredible the impact of these potentially small changes that they can make to your confidence.
And I suppose that's one thing there that just has popped into my head. How often would somebody come in and just say, I'm not happy, but I don't know what it is? Or do some people just say, I want you to do this bit and this bit? Or is it through your experience, you kind of get an understanding of what a balanced face should look like, and then they just go, over to you?
Yes, that's a really good question. So I have some patients who come in and are very specific. I want Botox, and we talk about it, and they'll say yes, or I don't want to have around my eyes done, or whatever else. On the whole, though, the majority of patients will come and say, what do you think? I think, my friend has had Botox, and I think it looks great. Do you think I'm the right sort of candidate for Botox? And then a lot of patients, I say a lot, a good number of patients will also, after having gotten to know me a little bit and having had a few things done, will say, look, over to you. I'm not really sure what I want, but I know I want to look better. What do you think? And what can we do? And I think they do that because they know I'm quite conservative and I'm not going to throw the kitchen sink at them at all. If anything, I'll just be like little increments. Because I think you want to try and do things as conservatively as possible on the whole. But equally, the nice thing about doing non-surgical aesthetics and surgery is that you have the whole armamentarium available to you. And so when there's a point at which a patient will come to you and say, I don't like the skin here, and you know that an energy-based treatment, let's say microneedling and radiofrequency, or radiofrequency alone, when you know that that treatment is not going to address the amount of laxity they have got, I can honestly turn around to them and say, I just don't think that's going to cut it for you. I think you are going to need to have some sort of surgical intervention if you want to be able to tighten your jawline by that much and try and get rid of these wrinkles. So that is, I think, the benefit of being someone who's got the sort of breadth of treatments under your belt.
Yeah, absolutely. Do you ever get people who have got totally unrealistic expectations, and they're like, I want to look like Angelina Jolie. And you're like, okay.
I want to look like Angelina Jolie. Yes, I have. So, I mean, lips are a classic thing. A classic thing that people want to change and address, and also one of those things where you have a limit as to what you sort of anatomically can take in terms of, let's say, filler, for example. So this is a thing that is very sort of, it's omnipresent. You walk down the street in central London and you see, a series of overfilled, markedly filled lips, which anyone, you don't need to have a surgery background to be able to sort of spot the lip filler down the street. So I do get patients occasionally who come and we do lip filler for them, and then they're like, oh, I think I want a bit more. But that's when the kind of patient-doctor relationship comes in, and being able to sort of say, well, actually, I think you're definitely on the upper end of what I would consider what would be an anatomically normal sized pair of lips for you. I think you look great. I don't think we should do any more. And on the whole, my patients have all sort of stuck with that. And And then occasionally I get a kind of funny selfie from them with a filter on with these massive lips. I got one, I think, the other day saying, "This is what I would look like if you were not my injector."
Yeah.
So there's that. And then, but then, you know, if I do get patients who come in typically having been injected elsewhere, the patient will say, "I'd like to have another 1 ml of lip filler." And you can see that the lips are already very, very full. And there's already quite a lot of migration. Then I do have quite an honest, very gentle but honest conversation to say, "I think if we take photos and we have a look, I think actually your lips take up quite a big proportion already, and you can see this migration. So actually, if we put another 1 ml of filler in, it has nowhere to go. You know, you've already expanded out the lip mucosa as much as you can, and if you put more lip filler in there, it's only going to go up and out into your philtrum or down into outside of your mouth." So I think probably, I know you've not contemplated this, but the better thing might be to just dissolve a little bit. Dissolve this migrated filler and start again. And I think in all of my patients who I've had that experience with, there's only been one who said, "There's no way I can dissolve my filler. You know, I can only have more filler put in." But everyone else tends to think, "Oh, okay," and goes away. And then I get a message via my PA, and sort of it usually goes along the lines of, "I totally see what Georgie meant now, and I'd like to, you know, have the outside bits dissolved and we can start afresh."
Yeah.
So on the whole, I think I've been quite lucky. I've had very reasonable patients who kind of take advice and can sort of, take a step back and look at things with me quite rationally.
But I think that also comes down to your experience, your credentials, and your essence, let's say, because what was it, that thing recently, the BBL, where it shows the terrors and the negativity that can happen if you go to the wrong people who will just try and take your money and do something terribly.
Yes, that's a really tricky story, that one. I think it was incorrectly identified as being a sort of surgical procedure that was performed by plastic surgeons, when in fact I think it was not actually performed by a doctor at all, and that was a case, I believe, of liquid BBL being performed. It's a real tragedy for that lady and her family about the fact that she died as a complication of that. That's absolutely horrific. And yes, I would say to anybody listening or contemplating having non-surgical aesthetics, or surgery of course, but non-surgical aesthetics, as you know, in this country are not hugely well regulated.
Yeah.
And you don't necessarily have to be a doctor or a specialist nurse to be able to use filler. It's not a prescription medication if it doesn't have local anesthetic in it. It is just available to purchase and inject.
Yeah, people do it in like the nail shops now.
Yeah, I mean, as myself and my colleagues at Imperial College NHS Healthcare Trust, so that's Mary's and Charing Cross, where we have plastic surgery departments, we see complications of sort of inappropriate filler usage, sort of not being given in a particularly sterile fashion, so it becoming infected. We've seen problems with liquid BBL many times. Thankfully, never seen anyone who'd been so critically unwell from it to the point that they've passed away. But we have had patients who have ended up with sepsis. So in the hospital with IV antibiotics, having been injected by people who don't have any qualifications to give these fillers, and it's a real shame for the patient. It's really dangerous, and then you kind of end up having the patients being actually just really disappointed about the fact they tried to enhance their buttocks, in the one case I'm thinking about, and in fact they've ended up needing to have what we call an incision and a drainage, so actually drainage of an abscess from their bottom, so they've ended up with a big divot in it, having wanted to just enhance the sort of roundness of it in the first place. So it's a real shame.
That's and I think that is, with any of these, if you're having surgery, make sure you plan and make sure you get the best person for the job as well. I think there's lots of horror stories about people flying off to places such as Turkey or anywhere else because they think they're getting a good deal, but actually the ramifications and the fact the NHS won't repair it for you when it's abroad, will they? I think there's something like that if
Yeah,
there's
that's a great question, actually. So what we see as well, and we see it from patients who've come back from Turkey. I mean, don't get me wrong, there are some absolutely amazing surgeons in Turkey, but there are also, some surgeons who, just like in every country, who are not going to be as careful when it comes to their post-op follow-up. So I think the important thing, and traveling abroad for medical reasons, cosmetic tourism is what we call it, you just have to be sure that there are mechanisms in place to be able to seek a member of that team should you have any complications. And what I have seen is one patient I'm thinking of in particular, who was in the healthcare domain, who had gone over to Turkey, having been very kind of clever, well researched about it, and identifying a clinic where she could have her treatments done. And they said that they had an outposting in London should there be any problems.
Okay.
So she stuck around for about a week after breast work and abdominal, tummy tuck.
Yeah.
And she'd come back to the UK, and the wounds had started breaking down and discharging, and they were infected. And so she called the number that she had for, I think it was somewhere around sort of Harley Street, and couldn't get through to anyone. The telephone number wouldn't pick up, it would just go to an answer phone. And she had obviously done her due diligence to try and make sure that she could see someone from that team. She contacted the place that she had the surgery done. They said, "Oh, sorry, that doctor's actually on leave at the moment. There's no one available, you have to go to A&E." And so A&E we in the NHS, A&Es do pick up emergencies.
Yeah.
So if someone has an infected wound following abdominoplasty or breast work or whatever else, we do look after them in the context of it being an emergency. Let's say, for example, breast implants. If they become infected, really, they have to kind of come out. There's very incredibly rare that you have an exposed implant that you can see through the skin, through a wound, that you can leave in. You typically have to take them out. And yes, you're right, in that context, the NHS will never put them back in for you because that is a cosmetic operation, but they will help you get out of the tricky situation of getting rid of the infection, taking the implant out, closing everything up for you. So, I mean, the NHS does take on a huge amount of burden of cosmetic tourism.
Wow. There we go. Everybody be warned. Do it right or don't do it at all. And I guess, conscious of time now, are there any particular myths within your industry that you think are worth dispelling very quickly?
Yeah. So I would say, sort of a time limit, like we've already touched on, there being a time limit in terms of when you can have facial rejuvenation surgery. So there's, being in your 40s, you may well be eligible to have a facelift or neck lift. You'll be in the minority for sure, but it's not beyond the realms. Similarly, some patients come to me and say, "Oh, I'm definitely too old for Botox." There's no such thing. You may well still be a candidate to have Botox. And I think the other thing which touches back on what we talked about, lip filler, the one thing, a real bugbear of mine, is that filler needs to be replaced every 6 to 9 months. So that's not the case. I think it used to be thought that it would be metabolized and disappear within 6 to 9 months after having had filler, but it kicks around for years, and we know that. It depends on the type of filler that you have, but you do not need to have it replaced every 6 to 9 months. You need to just be with a reasonable, sensible injector. If your filler looks as though it has disappeared, oftentimes it will have just moved a little bit, so spread out a little bit. Doesn't necessarily mean it's a bad thing. In the lips, it can be a little bit of a telltale if you've got a moustache or filler. But that would be it, really.
Oh, wow. Wow, I mean, no, I could chat to you all day. I find all of this super fascinating. However, we will continue the conversation on the 24th of October,
Yes.
when we will see you in person. But thank you so much, Georgina, for joining us.
Thank you too.
Everybody tuning in, either live or on the replay as well. If you do have any questions, I know one of you on Instagram would like to have the replay because you have to dig stuff out. But yeah, if you do have any questions, very happy to connect you with Georgina, and she is a world of knowledge and a safe pair of hands. So thank you so much for being here,
Thanks
and I'm
so
really
much,
looking
lovely.
forward to seeing you on the 24th.
See you on the 24th. Thanks.
Thank you.
Bye.
Bye bye.